first one we'll do, okay, first of all, let's go over our palpations. We need to go over our palpations. So when we're looking at the ankle and we're evaluating, we're going to get history and ask them all of our history questions. What happened? What was the mechanism of injury? What is his chief complaint? Why is he here? Because I'm going to get that history from him. And I want to observe, looking for signs of trauma, swelling, ecchymosis, deformities that might indicate a fracture. And where I really want to look specifically is this area right here. Remember I mentioned the sinus tarsi of the ankle? This is known as the sinus tarsi, that little kind of dimple divot. I was talking to you about it the other day in class. This is the area of the sinus tarsi. Okay? So if there's swelling, a lot of times that is where the swelling will go, whether it's from a high ankle sprain, whether it's from a low ankle sprain or an inversion sprain. You'll see puffiness in that area of the sinus tarsi. Okay, so the swelling usually goes there. So I want to look there specifically. Is there any swelling? I want to look down in here, and I want to look over here in the area of the foot. So sometimes gravity will draw the swelling and fluid down into the foot. So I want to see if I can bilaterally compare, okay, and see if I can see those bones of the foot, the tendons of the foot. A lot of times when there's swelling, you won't be able to see those tendons pop up like those there. Okay, so looking for those areas for swelling. Also looking in the medial malleolus, around the medial malleolus, and for an eversion sprain, I will get swelling in the medial malleolus. Okay, so looking for signs of is there swelling, and can I tell? The other thing I want to look at, obviously the foot structure, it's got a pretty high arch, things like that. Does he have hammer toes or anything that I want to, make a note of? But he's got some pretty high arches, so that could be an indication of maybe some hypomobility of the foot. Okay. All right, so I've done my observation. My special tests now, or actually my palpations next. I want to palpate the bones of the foot and ankle away from the area of the injury first. Okay, so I'm not going to directly palpate on the spot that hurts the most first off. Okay, so I want to kind of start on the other side maybe. So I'm going to palpate around this area here. What ligament is right here? The area right under the medial malleolus. There's a triangular shaped band made from 3 separate ligaments that becomes injured in an eversion sprain. What ligament is that? Okay, so the deltoid ligament, so I might palpate. If I have a lateral ankle sprain, I may start with the structures on the medial side first. I'm going to palpate the medial malleolus for tenderness. So you want to rule out fracture first, so you probably want to go over bony palpations first. Okay. Palpate the talus on the medial side. Okay, I can find the talar dome right there, inside that area right there. Okay. And then as I move over to the area of more point tenderness, or the area where the injury occurred, okay, I want to kind of, again, move towards it. So I may feel the bones of the foot, make sure that those are all intact. A lot of times in an inversion sprain, you can actually fracture the base of the fifth metatarsal. We talked about that. Remember, that's the Jones fracture in the foot. So if he had that mechanism, I may want to rule that out first. Is the tendon here? No, not really. Okay. So then I move over to my lateral malleolus. Again, we always want to bilaterally compare, but I'm just trying to show both you guys, both sides where you're palpating my lateral malleolus. And then I'm going to get to the point where, okay, this is an inversion sprain. I'm going to suspect injury to the lateral structures, all right? So these structures in here, the ligaments. The most commonly sprained ligament of the ankle is going to be your ATFL, or your anterior talofibular ligament. So my talus is in here. That's right. That's the point in the sinus tarsi that I mentioned. You put your finger right in that sinus tarsi, and you're going to palpate that ATFL, or the anterior talofibular ligament. So right there. Okay. Most commonly sprained ligaments. So ATFL. Then you have your CFL, or your calcaneofibular ligament. So calcaneus, fibula. So right in here. Okay, is going to be my calcaneofibular ligament. Here's my ATFL. Okay, sinus tarsi. Anterior surface, talofibular ligament, right in there. Okay, your sinus tarsi. ATFL, CFL. Okay, calcaneus. tibial ligament, right in there. You can actually palpate that one. That one's very palpable. All right, so ATF, so I'm going to palpate those two, the most commonly sprained in an inversion sprain. Talofibular ligament, calcaneal. And you also have a posterior, so when I say anterior talofibular, you have a posterior talofibular. So posterior behind the fibula there, if I can dig my finger back in there, I can try to get into the talus. This is, again, those people that complain of Achilles pain and say, oh, I sprained my ankle, but my Achilles hurts too. Well, it's probably not their Achilles. They just feel it back here somewhere. It's probably their posterior talofibular ligament, or it could be their posterior tibiofibular. It's up higher. So just be aware of that. They're going to complain of Achilles pain, and it's not going to be their Achilles. Okay, so those are those ligaments there. Now for the syndesmosis, or we said that high ankle sprain, if the syndesmosis is that articulation between the tibia and the fibula that isn't supposed to move. You have a little ligament right there. Okay, so if I kind of palpate, kind of feel my tibia here, my fibula here, and if I palpate to where that tibia starts, so right about there, that's where the ligament is. Okay, I can actually feel it. So anterior tibiofibular ligament. So don't get that confused with talofibular. Tib-fib. So anterior tibiofibular ligament, anterior talofibular ligament, calcaneal CFL. Right, so those are the ligaments, and then we also mentioned the deltoid. So those are the main ligaments I want you to be able to find and palpate. Special tests, anterior drawer test. Okay. You can have the patient lying down like this. Remember the 5 things that I said you need to know? Patient position, examiner position, so you as the clinician or the examiner, where do you sit, where do you stand, how do you position your hands, the direction of stress that you're supposed to apply to the tissue, what is a positive sign, okay, and what is the indication of that positive sign. So if I have a positive sign of pain, what does that mean? Or a positive sign would be an empty end field, or a positive sign might be that they have relief of their symptoms. So we need to know what is a positive sign, and then what does that indicate. Okay, so that's really important. Okay, so we're going to start with our anterior drawer test of the ankle. All right. So I can either have him laying down or sitting. You sit like you're sitting in a chair. Sometimes it's easier to get them. You know, if they have a lot of neural tension or tight hamstrings or tight calves, if their legs are extended, it's a lot of tightness on the ankle. So what I'm going to do is have him just relax, okay? I'm going to grab his calcaneus like this, okay? I'm going to stabilize the tibia and just have him relax. Put him kind of in a neutral position, maybe slightly plantar flexed, and I'm going to pull forward like I'm trying to open a drawer. Okay, so that's what it's called, the anterior drawer. I'm moving in an anterior direction, okay, so he's relaxed. I'm pulling forward, trying to open the drawer, and what I'm doing here is I'm stressing the ATFL, the anterior talofibular ligament. Okay, so when I'm grabbing the calcaneus, I'm pulling on the talus. So it's pulling that talus anteriorly, and I'm trying to feel for the end feel of that ATFL ligament. So stabilizing with one hand the tibia, pulling with the other hand in an anterior direction, the stress hand. Positive sign would be an empty end feel or even pain for him. Okay, if it's a minor sprain, there might be a nice solid end feel, but he'll feel pain with that. So that's the anterior drawer. Taylor tilt is checking for 2 different ligaments. If I tilt this way, so again I'm trying to get the talus to move. If I tilt this way, I'm checking or stressing the CFL ligament, or the calcaneofibular ligament. If I tilt this direction, the B version, I'm stressing the deltoid ligament, right? Okay, so on this side. Same thing, he's just going to kind of relax right there. And I'm just going to grab the calcaneus, and I'm going to tilt, I'm going to kind of move it inversion and then kind of put some overpressure, checking for that ligament. Okay, it's got a nice solid end feel. Then I'm going to move into eversion and apply overpressure and feel for that deltoid ligament. So it's got some good life in there. Let's try this side. Relaxing, more relaxing over here. Sprain either ankle before. And so we always want to bilaterally compare because he might have sprained his ankle before, or maybe never sprained his ankle before, and now we have something to compare against. So in my history, I want to know that. Have you ever sprained either ankle? So I know, well, maybe my baseline comparison isn't going to be a good one because now they're both loose. Okay. But really, I'm checking for that end feel. Do I have an end feel? So if I tilt into eversion, I'm stressing the deltoid ligament. If I tilt into inversion, I'm stressing the CFL. We're talking. And if anybody has any questions at any point, percussion test. There's two tests for fracture in the lower leg. One is percussion.